Hi guys, I'm Dr. Kaushik and today we're going to be looking at inhalational agents. Inhalational agents are the most common drugs which are used for the maintenance of general anesthesia. So we've already seen that we induce the patient with an intravenous agent which is injected into your IV cannula. Subsequently, you need to maintain the plane of general anesthesia, and this is done most commonly using your inhalational agents. So, ether was the first anesthetic agent which was used by W.T.G. Morton for the maintenance of anesthesia. That is something you need to remember. So another thing which is important is your Guedel's stages of anesthesia, wherein you have 4 stages. This has already been covered in another lecture, but there's no harm in going through it again. The first stage is the stage of analgesia, wherein you have a loss of painful sensations. The second stage is the stage of excitement, wherein the patient more often than not gets into a combative behavior. So this is a stage that you're trying to reduce constantly using faster acting anesthetic agents. The third stage is the stage of surgical anesthesia, and this is where you want the patient to be in the third stage of surgical anesthesia. And finally, stage 4 is the stage of medullary depression. This is something you want to avoid, wherein you can have stage of overdose of your drugs leading to medullary paralysis and subsequently can cause death also. So again, looking at the stages, the first stage is a stage of analgesia. From the time you give your medication to the time you have a loss of consciousness. The second stage is where you have your stage of excitement or delirium, which begins from the loss of consciousness and ends with the loss of your eyelash reflex. And again, like we saw, this is the stage that you're trying to minimize by having faster acting anesthetic agents. The third stage is a stage of surgical anesthesia, and this is where you want the patient to be in as soon as possible. And this lasts from the time you have a loss of your eyelid reflexes to the loss of most other reflexes and a depression of your vital functions. So here the patient is deeply unconscious and he appears to be in a relaxed phase. However, they cannot protect their airway, and this therefore needs a mechanical ventilation in order to support your respiratory drive. The stage 4 is your stage of medullary depression, wherein you're going to have a depression of your vital functions leading to circulatory and respiratory failure. This is something, this fourth stage is what you want to avoid. The second stage, again, you need to cut it short to as short as possible. Now, coming to classification of your volatile agents, you can either have pure gases such as xenon and nitrous oxide, or you can have volatile liquids. These volatile liquids, again, you have the older generation ones and the newer generation ones. The older agents being ether, and of course, most of these are for historical interest. You have ethyl chloride, you have chloroform, and cyclopropane. The newer agents which are currently in use are halothane, isoflurane, desflurane, and sevoflurane. All of these are volatile liquids which, given suitable conditions, they're going to vaporize and produce a gas, and this gas is going to be used for maintaining balanced anesthesia. So how do these gases act? They act via a variety of mechanisms. Most commonly, you have your NMDA antagonism. Nitrous oxide and xenon tend to act via NMDA antagonism. You can also have GABA receptor agonists. You can have a depression of your excitatory neurotransmitter conduction in the brain and the spinal cord. So again, you have two hypotheses to explain the way these volatile agents act. You have the Mayer-Overton hypothesis and you have the critical volume hypothesis. Mayer-Overton hypothesis says that the volatile anesthetic potency is directly proportional to its lipid solubility. We're going to be looking at this particular hypothesis in the upcoming slides. Your critical volume hypothesis says that the volatile anesthetic binds to a phospholipid bilayer, and this binding beyond a certain level tends to alter the membrane function of the neurons. And this is believed to explain the mechanism of action in a better way. So another important concept is the blood gas partition coefficient. Whenever we look at your volatile anesthetics, we always need to remember what is a blood gas partition coefficient. This blood gas partition coefficient is a term used to describe how much an agent is soluble in the blood. So the partition coefficient basically refers to the ratio of concentration of the substances in one medium to the ratio of concentration of substances in the second medium. And this is usually taken at 37 degrees Celsius. So it follows that a gas with a higher blood gas partition coefficient will be more soluble in the blood. So whenever this gas enters into the alveolus, from the alveolus it enters into the blood vessel. Because of its higher blood gas partition coefficient, more amounts of it will dissolve into the blood, and less amounts will be available to cross across the blood-brain barrier and act on the target tissue, that is the brain. So therefore, whenever you have a anesthetic gas with a higher blood gas partition coefficient, more amounts of it will be soluble in the blood, less amounts will be available to diffuse across the blood-brain barrier and act on the brain, and therefore it will have a longer onset of action. So again, to reinforce, gases with a higher blood gas partition coefficient will be slower to leave the blood and act on the brain tissue, and therefore the induction of anesthesia will be slower with these agents. And so it follows that your blood gas partition coefficient is inversely proportional to the rate of onset of anesthesia. So this is something which we need to remember. Blood gas partition coefficient refers to the solubility of the volatile anesthetic in the pulmonary circulation. So like we have seen, higher the blood gas partition coefficient, greater is its solubility and uptake in the pulmonary circulation. However, this higher solubility results in a slower rise of your alveolar partial pressures, and this leads to a prolonged induction like we saw earlier when the blood gas partition coefficient is high. Therefore, your inhalational induction with agents with higher blood gas partition coefficient results in a prolonged induction, and blood gas partition coefficient is therefore directly proportional to the solubility of your volatile anesthetic in blood, and it is inversely proportional to the rate of rise of your alveolar concentration, and it is also inversely proportional to the rate of induction and recovery using that agent. So this is something which is very, very important. It is repeatedly asked. Please make it a point to remember the blood gas partition coefficient of at least some of the most important ones which I am going to outline. Xenon has a blood gas partition coefficient of 0.14, and therefore it tends to have the fastest onset and recovery. On the other hand of the table, you have your methoxyflurane, which has a blood gas partition coefficient of 15, and therefore it has the slowest onset and recovery. The agents that we commonly use, desflurane has a second lowest blood gas partition coefficient of 0.42. Nitrous oxide again is very commonly asked. You have a blood gas partition coefficient of 0.47. Sevoflurane has a blood gas partition coefficient of 0.69. Isoflurane has a blood gas partition coefficient of 1.38. Halothane again is something which acts quite slowly. It has a blood gas partition coefficient of 2.4. So these are the things you need to remember. Xenon with a blood gas partition coefficient of 0.14 has the fastest onset and recovery. Methoxyflurane with the blood gas partition coefficient of 15 has the slowest onset and recovery. The more common used ones today, like your desflurane, sevoflurane, isoflurane, and halothane, come in between these two, and all of these are halogenated compounds. These are the ones which are presented to us as a liquid, and they vaporize, produce a gas which is used to maintain your anesthetic levels. So the next concept that we need to understand is your oil gas partition coefficient. So like we saw earlier, your partition coefficient refers to the concentration of the gas in one medium to the second medium. So your oil gas partition coefficient therefore refers to the concentration of your gas in olive oil in proportion to the concentration of the volatile anesthetic existing in the gas phase. So olive oil is what is used for purposes of standardization, and this therefore gives you an idea of the lipid solubility of the volatile agent. Now, why is this important? Once a molecule is more lipid soluble, it tends to cross over. We saw earlier that it has to diffuse from the alveolus into the blood. From the blood, it has to cross over through the blood-brain barrier to act on the receptor in the target tissue, that is the brain. So whenever you have something which is more lipid soluble, the molecule which is more lipid soluble, it will find it easier to cross over through a lipid rich blood-brain barrier and then into your brain tissue to act on the target receptor. So your oil gas partition coefficient will determine the potency of your anesthetic agent. So therefore, it follows that volatile anesthetics with a higher oil gas partition coefficient will tend to be more potent, as they will be able to cross over from the blood vessels through the blood-brain barrier and act on your fat-rich tissues of the central nervous system more easily. On the other hand, volatile anesthetics with a lower oil gas partition coefficient will stay in the blood vessel and require higher amounts of gas to cross over through the blood-brain barrier and act on the central nervous system. So to summarize, your blood gas partition coefficient will determine the speed of induction of your anesthetic agent, whereas your oil gas partition coefficient will determine the potency of the volatile anesthetic. Next, we shall look at the minimum alveolar concentration. Now, what is the minimum alveolar concentration? This is nothing but the concentration of the gas which prevents movement in 50% of unpremedicated patients to a standard skin incision taken at 1 atmosphere pressure. So the important points we need to remember are that it is an unpremedicated patient and you're looking at the motor response to a skin incision, and you take it at 1 atmospheric pressure or at sea level. So these are the things that we need to remember. And whenever we're looking at the minimum alveolar concentration, it is assumed that the minimum alveolar concentration is a direct reflection of the concentration of the gas within the brain, because your brain tissue receives a lot of blood supply through a lot of blood vessels, and therefore the minimum alveolar concentration is taken as the concentration of the volatile anesthetic in the brain. Now, why is this important? This minimum alveolar concentration is the best measure of potency of your inhaled agent, and it is equivalent to the ED50 of any intravenously injected drug. This minimum alveolar concentration does not vary across a wide variety of noxious stimuli, and it does not vary according to the age, sex, height and weight of the patient. Now, why are we so bent upon the unpremedicated status of the patient? Premedication tends to reduce your minimum alveolar concentration, and therefore whenever you're standardizing the minimum alveolar concentration, you need to do it in an unpremedicated patient at 1 atmospheric pressure and to a standard skin incision, and you're looking at the motor response. So you have other MAC values such as your MAC awake, MAC bar and MAC recall. MAC bar is the MAC which prevents an adrenergic response in 50% of individuals, which is around 1.7 to 2 times the MAC value which prevents a motor response. MAC recall is the MAC which prevents a recall in 50% of the individuals, which is again a little lesser than your MAC. It is 0.3 to 0.5 times the MAC value. The next thing we need to look at as far as the minimum alveolar concentration is concerned is the factors that reduce and increase your MAC value. So agents such as your nitrous oxide tend to reduce your MAC value. We've already seen that pre-medication with opioids, benzodiazepines and sedatives tends to reduce your MAC value. There are certain diseases like your hypothyroidism which tends to reduce your MAC value. Anemia and pregnancy again reduce your MAC value. Factors which increase your MAC value are hyperthyroidism. On the other hand, you have hypothyroidism which reduces it. Hyperthyroidism tends to increase your MAC value. You can also have hypercapnia and hyperthermia which tend to increase the MAC value. Important to remember here is that weight, sex, height does not have any impact on the MAC value. So when it comes to your minimum alveolar concentration, we need to remember that the MAC value is additive. And when we're talking about the additive nature of the MAC value, we are discussing only about nitrous oxide because the other volatile anesthetics are never used in combination. So what do you mean by the additive nature? It means that if you use half MAC of one agent and half MAC of another agent, the combined MAC value would be 1. So this is valid again, as we discussed earlier, it is valid only for nitrous oxide because the other fluorinated agents are not combined. So again, you need to remember the MAC value of all your important commonly used volatile anesthetic agents. So we see here that methoxyflurane is the fluorinated agent which has the least MAC value of 0.16 and it is therefore the most potent fluorinated volatile anesthetic agent available. Nitrous oxide with a MAC value of 104 is the least potent. However, this is not a fluorinated agent. Amongst the fluorinated agents, you have desflurane with a MAC value of 6.6, which is the least potent fluorinated volatile anesthetic agent available. Halothane has a MAC value of 0.74. Again, it becomes more potent because of this. Isoflurane has a MAC value of 1.15. Sevoflurane has a MAC value of 2. So these are values you need to commit to memory. Please don't underestimate this because it is often asked in your exams. This is another slide which looks at the different features of all of these volatile anesthetic agents. The most commonly used ones, halothane has a MAC value of 0.75. Sevoflurane has a MAC value of 1.8. Desflurane has a MAC value of 6.6. Again, your MAC value, because of the different potencies of these agents, it tends to increase from your halothane across to desflurane. The blood gas partition coefficient of desflurane is 0.42. And so therefore, amongst the fluorinated agents, this is the most rapid acting. Your blood gas partition coefficient of halothane, again, like we saw earlier, is 2.4 and therefore it has the slowest onset. Now, important thing to remember amongst the other features is that halothane and sevoflurane, these tend to be non-irritant to the respiratory tract and therefore they can be used for induction in patients where you do not have an IV line. The other agents such as your isoflurane and desflurane tend to be irritant and can precipitate your laryngospasm or bronchospasm. So now we know that halothane and sevoflurane are non-irritant to the respiratory tract and therefore they can be used for induction of anesthesia in patients who do not have an IV line. Desflurane and isoflurane, on the other hand, are irritants to the respiratory tract. Desflurane being a lot more irritant to the respiratory tract and therefore can result in a lot of airway reactivity. Now, the important thing as far as halothane is concerned, halothane, when you have recurrent exposures to halothane, you can have something which is called as halothane hepatitis. It tends to affect the liver. We shall again be looking at it in more detail. For patients who have a history of halothane hepatitis, you're going to revert to sevoflurane, which is a drug of choice to maintain anesthesia in these patients. Now, what about sevoflurane? Sevoflurane The side effect being that it can generate a compound called as compound A, and this compound A has significant nephrotoxic potential. So these are the significant side effects of some of the more commonly used inhalational agents. So this is another table which brings out all the important features as far as the usage of these commonly used volatile anesthetics is concerned. Isoflurane tends to be preferred whenever you have a patient who requires hypotensive anesthesia. It is also very commonly used for cardiac surgery. Sevoflurane, as we saw earlier, is non-irritant to the respiratory tract, and therefore you can use it for induction of anesthesia. It is also the preferred agent for neurosurgeries and also daycare procedures. So the commonly occurring side effects are halothane hepatitis as far as recurrent exposures to halothane is concerned, and with sevoflurane you can have a compound A generation which results in nephrotoxicity of this particular agent. Now let's look at some of the salient features of the individual agents. First being your desflurane. So desflurane, like we saw earlier, it has a very low blood gas partition coefficient, the lowest amongst all of your halogenated agents, and therefore it has a rapid onset and recovery. We learned earlier that your blood gas partition coefficient refers to the solubility of your drug in the blood, and therefore your volatile agents which are more soluble in your blood will find it difficult to cross across the blood-brain barrier and act on the target tissue. So you would prefer agents who have a lower blood gas partition coefficient so that more amount of your gas is available in a gaseous form so that it can cross across the blood-brain barrier and act on the central nervous system. So desflurane, therefore, with a low blood gas partition coefficient of 0.42 will have a rapid onset and rapid offset of its actions. However, it has a relatively higher oil gas partition coefficient of 29. We saw that the oil gas partition coefficient refers to the potency of the agent, and therefore your desflurane is a little less potent as compared to other volatile anesthetic agent, which therefore leads to a higher MAC value of 6.6. Amongst all the commonly used fluorinated agents, desflurane has the highest MAC value of 6.6. This is almost 1/5 the potency of isoflurane. Other important things we need to remember is that it acts as a respiratory irritant, and therefore you can have a bronchospastic episode if you induce the patient with a desflurane. It is also a sympathetic stimulant, can lead to transient tachycardia on induction, and it is the drug of choice in obese, in the elderly patients, and in daycare surgeries. When it comes to isoflurane, this is a volatile inhalation agent which is used most commonly for the maintenance of anesthesia, and like we saw earlier, it is a preferred agent whenever you're going to look at cardiac surgeries and where you need hypotensive anesthesia. So it has a relatively higher blood gas partition coefficient of 1.4. This makes it a relatively slow acting agent. The oil gas partition coefficient of 98 makes it a relatively more potent agent. This oil gas partition coefficient is therefore considerably high, and it has a MAC value of 1.17. Again, like your desflurane, it is irritant to the respiratory mucosa, so you're not going to use isoflurane for inhalational induction. It undergoes minimal metabolism in the body. The important thing as far as isoflurane is concerned, it offers a degree of cardiovascular stability, and therefore you're going to prefer isoflurane as the agent of choice for patients undergoing cardiac surgery, and also for those who require hypotensive anesthesia. When it comes to sevoflurane, we've already seen that it does not irritate the respiratory mucosa, and therefore this is the drug of choice for inhalational induction. This is something you need to remember. This is the drug of choice. Sevoflurane is a drug of choice for inhalational induction in patients where you do not have an IV line. It has an oil gas partition coefficient of 80, which is comparatively less when you compare it with desflurane, but your 80 is still a little high, so it is relatively less potent with a MAC value of 1.8. The blood gas partition coefficient is 0.7, so this is relatively low, and therefore sevoflurane has a rapid onset and offset of action, which would lead to its preference in daycare surgery. So whenever you have a patient who undergoes daycare anesthesia, sevoflurane would be the preferred agent for maintenance of anesthesia in these patients. Again, because of the non-irritant nature during inhalation, you're going to have sevoflurane, which is preferred as the inhalational as the drug of choice for your inhalational induction. Again, the side effects with sevoflurane, you're going to have compound A generation as well as fluoride ion generations, which leads to the nephrotoxic potential for as far as sevoflurane is concerned. Just like your isoflurane, sevoflurane also tends to undergo minimal metabolism within the body. When it comes to halothane, halothane, like we saw, is a sweet smelling compound. It does not irritate the respiratory tract. So if sevoflurane is not available, your halothane would turn out to be the second drug of choice for inhalational induction, those patients who do not have an IV line. It has an oil gas partition coefficient of 197, which is quite high, and therefore it tends to be more potent, leading to a MAC value of 0.75. A blood gas partition coefficient of 2.5, which is less, and like we saw, your blood gas partition coefficient, those agents with a higher blood gas partition coefficient will have a slower onset and slower offset of your anesthesia, and therefore halothane will have a slower onset of anesthesia as compared to other inhalational agents. On the different systems, halothane tends to be a myocardial depressant. It can lead to bradycardia, and it also sensitizes the heart to catecholamines. These are three things you need to remember as opposed to desflurane, which has a transient sympathomimetic action. Halothane tends to be a myocardial depressant. It causes bradycardia and it sensitizes the heart to catecholamines. Another important thing with halothane is that it causes bronchodilation, and therefore it is the drug of choice for maintenance of anesthesia in asthmatic patients. On the central nervous system, it tends to increase the cerebral blood flow and the intracranial pressure, and it is also a powerful uterine muscle relaxant. These are important things you need to remember about halothane. Like we saw earlier, halothane tends to result in halothane hepatitis on repeated exposures to halothane, and this would, if at all you have a patient who has a history of halothane hepatitis, your drug of choice in those patients would be sevoflurane. Another important thing as far as halothane is concerned, it can lead to malignant hyperthermia. We will be looking at each one of these separately. Another drug which was used commonly was methoxyflurane. Methoxyflurane, we need to remember, is the most potent inhalational agent. It has an oil gas partition coefficient of 950. Therefore, it is the most potent inhalational agent with a MAC value of just 0.2. However, the blood gas partition coefficient is 12, which leads to a slow onset and recovery. So methoxyflurane, we need to remember, just like your sevoflurane, it tends to be toxic to the renal vasculature because of the production of fluoride ions and can result in a vasopressin resistant high output renal failure. So these are things you need to remember about methoxyflurane. It is also hepatotoxic. So next, let's look at the salient features of nitrous oxide. Nitrous oxide has a molecular weight of 44 daltons. It has a boiling point of minus 88.5. It has a critical temperature of 36.5 degrees Celsius. What is important for us is your blood gas partition coefficient of 0.47, which tends to make it very rapidly acting agent. However, your oil gas partition coefficient of 1.4 is quite high. Therefore, it tends to have a MAC value of 105, making it amongst the less potent inhalational anesthetic agents. So therefore, your nitrous oxide is often not used as a sole anesthetic. It is always used in combination with something else like your desflurane or sevoflurane. This nitrous oxide is used for its analgesic and anxiolytic properties in combination with oxygen, and this is commonly used in dental extractions and for labor analgesia. So as far as nitrous oxide is concerned, these are things you need to remember. It is used for labor analgesia. It is often used in combination because of its low potency and a MAC value of 105, and it has a blood gas partition coefficient of 0.47, making it a relatively quicker acting agent. When it comes to xenon, xenon is a pure inert gas and it is closest to the ideal anesthetic agent which is available. However, it is not approved for clinical use. Why is it closest to your ideal inhalational anesthetic? It has the fastest onset and recovery on accord of its blood gas partition coefficient of 0.14, and it has a lowest potency with a MAC value of 70%. Now, this xenon exerts its action via the NMDA receptor antagonism. It does not undergo any metabolism being an inert gas. However, there is a risk of malignant hyperthermia and it can cause environmental pollution as well as occupational hazards. So, it is not approved for clinical use. However, it is the closest we have to an ideal inhalation anesthetic agent. So, what are the properties of these inhalational agents that we need to remember? The pharmacodynamic properties which are important, all of these agents tend to increase the intracranial pressure by causing cerebral vasodilatation. All of them tend to reduce your cerebral metabolic rate except for nitrous oxide, and therefore you do not use nitrous oxide in neurosurgeries. All of these agents tend to cause muscle relaxation, again except for nitrous oxide. All of them again tend to trigger malignant hyperthermia except for your nitrous oxide. And all of these volatile agents are myocardial depressants, again except for your nitrous oxide. And most of them will cause short and fast breathing due to an increase in the respiratory rate and decrease in your tidal volume. So these are important pharmacodynamic properties that we need to remember about all of these inhalational agents. So let's look at some questions now. The first question is about blood gas partition coefficient. Is blood gas partition coefficient a measure of the potency of the agent? Is it a measure of the speed of induction and recovery? Is it a measure of the lipid solubility of the agent, or none of the above? So like we saw earlier, blood gas partition coefficient, it refers to the solubility of the volatile anesthetic in blood, not in lipid. Therefore, higher the blood gas partition coefficient, greater will be the solubility and uptake in the pulmonary circulation. Slower will be the rise in the alveolar partial pressure, and this would lead to your prolonged induction when the blood gas partition coefficient is high. And so therefore, inhalational agents with higher blood gas partition coefficient will result in a prolonged induction. So blood gas partition coefficient therefore correlates with the speed of induction and recovery. It is not related to the potency of the agent, for which your oil gas partition coefficient is the one which correlates with the potency of your volatile anesthetic agents. So I think we can answer this question now. Blood gas partition coefficient is a measure therefore of the speed of induction and recovery. It has nothing to do with the potency of the anesthetic agent or the lipid solubility of the anesthetic agent. The next question. Which of the following inhalational anesthetic agent most easily crosses the blood-brain barrier? Is it methoxyflurane? Is it sevoflurane? Is it desflurane? Or is it nitrous oxide? So like we saw earlier, you're crossing over the blood-brain barrier. The ease of crossing over is going to be determined by the oil gas partition coefficient. Again, these numbers are very important for us. We already saw that the oil gas partition coefficient refers to the potency of the agent. So, nitrous oxide has the least oil gas partition coefficient of 1.4, and therefore it is the least potent. Therefore, it has the highest minimum alveolar concentration. Minimum alveolar concentration refers to the concentration which is required to suppress a response to skin incision in 50% of the individuals at atmospheric temperature. Point to be noted is that these individuals have to be unpremedicated. Methoxyfluorine, on the other hand, has the highest oil gas partition coefficient of 950. Therefore, it has the least MAC value of 0.2. This is something you need to remember. Halothane has a oil gas partition coefficient of 224, and therefore amongst the commonly used volatile anesthetic agents, this has the lowest MAC value of 0.75. And again, amongst the commonly used anesthetic agents, your desflurane has the lowest oil gas partition coefficient and therefore the highest MAC value of 6.6. Sevoflurane and isoflurane, on the other hand, lie in between these values. Sevoflurane has a MAC value of 2, isoflurane has a MAC value of 1.2 and is therefore more potent as compared to sevoflurane. So, I think we can answer this question now. Which of the following inhalational anesthetic agent most easily crosses the blood-brain barrier? The correct answer therefore is A, methoxyfluorine, because it has the highest oil gas partition coefficient, resulting in a very easy passage across the blood-brain barrier into the brain tissue. So, let's look at the next question. What is the critical temperature of nitrous oxide? Is it minus 118 degrees Celsius? Is it minus 88 degrees Celsius? Is it plus 36.5 degrees Celsius? Or is it minus 36.5 degrees Celsius? So, to answer this question, we need to know what is the critical temperature and pressure. Critical temperature is the temperature at which a gas cannot be liquefied however much pressure is applied. Critical pressure, on the other hand, refers to the minimal pressure which will cause a liquefaction of the gas at its critical temperature. Now, why is this important? Critical temperature of nitrous oxide is 36 plus 36.5 degrees Celsius. Now, this means that beyond 36.5 degrees Celsius, however much pressure you apply, nitrous oxide will not be converted into a liquid. However, below 36.5 degrees Celsius, nitrous oxide can be liquefied and stored in the liquid state. So, since the OR temperature is below 36 degrees Celsius, nitrous oxide is usually provided to us in a liquid state. So, you can see here the tank with nitrous oxide is going to be provided to us in a liquid state. Now, what about oxygen? The oxygen has a critical temperature of negative 118 degrees Celsius. So, since you cannot have an OR temperature which is so low, oxygen cannot be provided to us in a liquid state. It is always given to us in a gas form. So, the oxygen cylinder will have oxygen present in its gas form. The nitrous oxide cylinder will have the gas, that is nitrous oxide, provided to us in a liquefied state. Why? And so, therefore, I think we can answer this question that critical temperature of nitrous oxide is plus 36.5 degrees Celsius, which is your option C. Now, the next question is about the critical temperature of oxygen. What is the critical temperature of oxygen? Is it 20 degrees Celsius? Is it minus 118 degrees Celsius? Is it plus 36.5 degrees Celsius, or is it 400 degrees Celsius? So, like we saw earlier, critical temperature is the temperature at which a gas cannot be liquefied however much pressure is applied to it. Critical pressure, on the other hand, is the minimal pressure which causes liquefaction of the gas at its critical temperature. So, we need to remember critical temperature of nitrous oxide is positive 36.5 degrees Celsius. Remember, they can confuse you in your exams with a negative value and a positive value. You need to remember whether it is positive or negative. Nitrous oxide, it is positive 36.5 degrees Celsius. So therefore, it is provided to us within the cylinder in a liquid state. Oxygen, on the other hand, has a critical temperature of negative minus 118 degrees Celsius, and therefore it is provided to us in a gas form. And because of this, your cylinder, which has a reading when it is fully filled with oxygen of 2000 psi at a capacity of 660 liters, when it is going to drop to half the value at 1000 psi, we can be sure that the capacity is only 330 liters of oxygen, because it is in a gas state. And so therefore, changes in the pressure gauge will reflect a change in the actual quantity of gas present in the cylinder. So the critical temperature of oxygen therefore is minus 118 degrees Celsius. Now the next question: which of the following anesthetic agent is the most lipid soluble? Is it nitrous oxide? Is it methoxyfluorine? Is it isoflurane? Or is it halothane? So some numbers again, important ones being nitrous oxide with a oil gas partition coefficient which is the least of 1.4, and therefore the MAC value is 103. Desflurane amongst the fluorinated agent has the least oil gas partition coefficient of 29, therefore the highest MAC value of 6.6. Methoxyfluorine has the highest oil gas partition coefficient of 950, and therefore it is the most potent with a MAC value of 0.2. Amongst the more commonly used volatile anesthetic agents, halothane has an oil gas partition coefficient of 224 with a MAC value of 0.75. CO and isoflurane are in between with an oil gas partition coefficient of 80 and 98 and a MAC value of 2 and 1.2. So these are numbers you have to commit to your memory. Please do remember them because it is often asked in your entrances. So therefore, I think we can answer this question. Which of the following anesthetic agent is the most lipid soluble? It is methoxyfluorine with an oil gas partition coefficient of 950 like we saw, and a MAC value therefore of only 0.2. The next question is about the boiling points. Amongst the following agents, the maximum boiling point is associated with sevoflurane. Is it B, isoflurane? Is it C, methoxyfluorine? Or is it D, desflurane? Again, this brings us to this picture which shows us the boiling point of the different volatile anesthetic agents used. So you have nitrous oxide with a boiling point of minus 88.5 degrees Celsius. Methoxyfluorine has the highest boiling point of 104.8 degrees Celsius. Sevoflurane has a boiling point of 58.6 degrees Celsius. Isoflurane has a boiling point of 48.5 degrees Celsius, and desflurane has a boiling point of 22.8 degrees Celsius. So like we have seen, the maximum boiling point therefore is that of methoxyfluorine. So the correct answer is C. Next, coming to the arm tongue time. So the arm tongue time is A, is it 13 seconds? Is it B, 15 seconds? Is it C, 20 seconds? Or is it D, 40 seconds? So for this, we'll have to look at what is your arm tongue time. So this can be explained by means of your blood circulation time. This is nothing but the time taken by a particle of blood to flow from one point in circulation to the other. So the principle is basically you inject drug into intravenously and then note the arrival of that drug at whichever point is in question. So here we are looking at the arm to tongue time. So therefore this will look at the time taken for a particle to go from the arm to your tongue. So it basically measures the linear velocity of blood, and for this you need to inject your 2% decoline. Around 5 ml of 2% decoline is injected into the antecubital vein, and the time taken for it to reach the tongue and give a bitter taste is what is taken as the arm to tongue time. This is usually between 8 to 16 seconds and an average of around 13 seconds. And similarly, you can have an arm to lung time wherein you inject intravenous ether in saline into the arm, and then you check for the presence of ether in your expired air. And this is taken as the arm to lung time, which is normally around 6 seconds. So we need to remember that the arm tongue time is around 13 seconds, and therefore the correct answer for this question is option A, 13 seconds. Your arm tongue time is usually around 13 seconds. So the next question, fast induction and recovery is seen with methoxyflurane. Is it B, ether? Is it C, halothane? Or is it D, nitrous oxide? So just mug up these numbers, guys. These are high yield questions and they are often asked in your entrance exams. You need to know each of these numbers by heart. So remember that xenon is the one which has the lowest blood gas partition coefficient, and therefore it has the fastest onset and recovery. It is not in clinical use. Methoxyflurane, on the other hand, has the highest blood gas partition coefficient and therefore the slowest onset and recovery. Amongst the commonly used fluorinated agents, your desflurane has the lowest blood gas partition coefficient and therefore the fastest onset and recovery. The fastest induction and recovery is therefore seen with nitrous oxide. Your correct answer is D. The next question, all of the following are true about nitrous oxide except that it is what is called as a laughing gas, can result in megaloblastic anemia. Is it that it causes diffusion hypoxia, or is it a good muscle relaxant? Which of these are true and which is the false option? So for this, we need to look at some of the salient features of nitrous oxide. Nitrous oxide is chemically dinitrogen oxide, and it is referred to as laughing gas because it lands your patient in a state of euphoria. So physically, this nitrous oxide tends to be colorless, it is non-flammable, and it is heavier than air with a slightly sweet taste and scent. So it has anesthetic properties because of your NMDA receptor antagonism, and it also has analgesic properties because of its endogenous opioids acting on the opioid receptors. The anxiolytic properties of nitrous oxide results from its GABA A activation. Unlike other volatile agents, however, it does not have any muscle relaxant properties. So nitrous oxide does not have any muscle relaxant properties. So the physical attributes of nitrous oxides, it has a molecular weight of 44 Daltons, boiling point of minus 88.5 degrees Celsius, a critical temperature which is little higher than the OR temperature at 36.5 degrees Celsius, and therefore nitrous oxide is provided to us in a liquid form in the cylinder. Your blood gas partition coefficient of 0.47 makes it the anesthetic agent with a very low blood gas partition coefficient, and therefore it has a rapid onset and recovery. Your oil gas partition coefficient, however, is 1.4. Therefore, your nitrous oxide is amongst the lesser potent anesthetic agent with a MAC value of 105. Important thing, it is non-flammable, but it supports combustion. So the other salient features of nitrous oxide, it has a central sympathetic stimulating action which helps in maintaining the SVR, the blood pressure and the cardiac output. It also tends to increase your cerebral blood flow, the intracranial pressure and the pulmonary vascular resistance, and therefore your nitrous oxide has fallen out of favor of late. So something which is very interesting when it comes to nitrous oxide. So when it is administered, Your nitrous oxide, like we discussed earlier, is often administered as an adjunct other volatile anesthetic agents. So it is often commonly delivered with a second gas. So what happens when you administer this nitrous oxide? So nitrous oxide, when it is administered, it diffuses down into the alveolus, and from there it is taken up more rapidly into the blood. That is, your air within the alveolus is comprised more of nitrogen as well as some amount of oxygen. Your nitrous oxide is being delivered, and this nitrous oxide diffuses across into the pulmonary vasculature much more faster than your nitrogen, because your nitrous oxide is almost 30 times more soluble than nitrogen in water. So what happens when your nitrous oxide diffuses across so rapidly into the pulmonary circulation? It leaves behind a void of that much volume within the alveolus. And so what happens? Your co-administered gas, such as your sevoflurane, tends to become much more concentrated because of this void which is created because of a rapid diffusion of nitrous oxide into the pulmonary circulation. This is what is your concentrating effect. So this void in turn is filled up by more and more volumes of sevoflurane, which is delivered through your anesthetic circuit. This is what is called as your second gas effect. So remember, nitrous oxide is 30 times more soluble in your pulmonary circulation than nitrogen. So when you administer nitrous oxide along with your sevoflurane and isoflurane as an adjunct, this nitrous oxide tends to diffuse across the alveolus much more rapidly, and so it leaves behind a void within the alveolus, and this void therefore tends to concentrate the remaining gases present within the alveolus. This is what is your concentration effect, and this void tends to be filled up by more and more quantities of your volatile anesthetic, which is called as your second gas effect. So this is what is very commonly seen with your nitrous oxide. It is asked very often in your entrance exams, so please do pay attention and learn up these concepts. So what happens when when the patient emerges from your anesthesia? When the administration of nitrous oxide ceases, the nitrous oxide which is present in the pulmonary circulation tends to enter into the alveoli much more rapidly than your nitrogen can leave it, and this causes a dilution of your gaseous contents within the alveolus, predominantly your oxygen content. This results in the dilution of your oxygen present within the alveolus at the time of emergence, resulting in diffusion hypoxia. This is something which is very important. Again, it is asked often, and it is also called as your Fink effect. So other important side effects when you use nitrous oxide other than your diffusion hypoxia tends to have a higher incidence of post-operative nausea and vomiting. Other important thing you need to remember is that nitrous oxide use irreversibly oxidizes the cobalt atom of vitamin B12 by reducing the activity of B12 dependent enzymes such as your methionine synthetases, and this would result in megaloblastic anemia. This is something which you need to remember. Therefore, I think we can answer this question. All of the following are true about nitrous oxide except it is also called as laughing gas. It can cause megaloblastic anemia like we saw, causes diffusion hypoxia or your Fink effect. It does not, however, cause any muscle relaxation. Therefore, the correct answer is D. It is not a good muscle relaxant. Next question. All of the following are false about nitrous oxide except it is the least potent. Is it a good muscle relaxant? Is it lighter than air? Or it does not cause diffusion hypoxia? So again, let's revise all the salient features. Like we saw, it is also called as laughing gas. It is colorless, non-flammable, but it does support combustion. It has anesthetic, analgesic and anxiolytic properties, but no muscle relaxant properties. We need to remember that it is a volatile anesthetic agent which does not have any muscle relaxant properties. It has a critical temperature of 36.5, so it is provided in liquid state. blood gas partition coefficient which is quite low of 0.47, making it a very rapid acting drug. It has an oil gas partition coefficient of 1.4, therefore it is very less in potency as compared with other volatile anesthetic agent. It has a MAC value of 105. It is non-flammable, but it does support combustion. Now the other features, it causes central sympathetic stimulation. It maintains your SVR and the blood pressure as well as a cardiac output. As a result of this, tends to increase your cerebral blood flow, the intracranial pressure and the pulmonary vascular resistance. It causes a concentration effect because it is 30 times more soluble in the blood as compared to nitrogen. So when you administer nitrous oxide from the alveolus, your nitrous oxide diffuses into the pulmonary circulation very rapidly, and this leaves behind a void which tends to concentrate the remaining gases present within the alveolus. This is what is called as a concentration effect, and this void which is created by the nitrous oxide is then filled up by the co-administered sevoflurane, which would result in a concentration of the sevoflurane which is being delivered, which is called as your second gas effect. The reverse happens when the patient emerges from anesthesia. Nitrous oxide tends to diffuse out rapidly from the pulmonary vasculature into the alveolus. So it dilutes all the gases present within the alveolus, especially your oxygen, leading to what is called as diffusion hypoxia or the Fink effect. Again, this is very commonly asked. Please do remember this. And other important side effects being it is commonly associated with post-operative nausea and vomiting, can again cause megaloblastic anemia and bone marrow depression on long-term administration, which can be prevented by co-administration of folinic acid. Also, your air-filled cavities, such as in a patient with a pneumothorax or a pneumocephalus, you would not administer nitrous oxide because it would diffuse into this air-filled cavity, tend to expand in size and volume. So therefore, these patients, your nitrous oxide would be contraindicated. So I think we can answer this question now. All are false about nitrous oxide. Again, this is extremely important. Your wordplay in exams, please do remember that they're going to frame the questions for you to get confused with the use of English language. So please do read it. All of the following are false. So you need to identify which of these statements is true. So option A, like we have seen, nitrous oxide is the least potent and it has a MAC value of 105, and therefore this is the correct answer. It is not a good muscle relaxant, it is heavier than air, and it does result in diffusion hypoxia. So these are all your false options. The next question. Ratio of oxygen to nitrous oxide in Entonox is it A 50:50? Is it B 60:40? Is it C 40:60? Or is it D 25:75? The blood gas partition coefficient of 0.47 makes it a fast onset and fast offset of action. Your oil gas partition coefficient of 1.4 leads to its least potent status with a MAC value of 105. Now, something we need to remember is that nitrous oxide cannot be used as a sole anesthetic agent because it is the least potent. It is often used in combination with a more potent volatile anesthetic agent. So, for its analgesic and anesthetic anxiolytic properties, this nitrous oxide is commonly used in labor analgesia and dental extractions, and this is often used in a ratio of 50 to 50%. So 50% of nitrous oxide and 50% of oxygen is what is used for your labor analgesia as your Entonox. So therefore, the ratio of oxygen to nitrous oxide in Entonox mixture is 50 to 50, and the correct answer is A. Next question, the MAC value of desflurane is it A 1.15, is it B 2, is it C 4, or is it D 6? So the numbers again, please do memorize them. Your MAC value of methoxyflurane is the least, and therefore it is the most potent. Nitrous oxide, the MAC value is the highest, and therefore it is the least potent. Desflurane has a MAC value of 6.6 amongst all the fluorinated volatile anesthetic agents. Your desflurane has the maximum MAC value and it is therefore the least potent. Halothane, on the other hand, has a MAC value of 0.74. Amongst the clinically used volatile anesthetics of late, your halothane is the one which has the most potency with the least MAC value of 0.74. Isoflurane with a MAC value of 1.15 and sevoflurane with a MAC value of 2 fall in between. So the MAC value of desflurane is therefore 6 and your correct answer is D. Next question, following is true about halothane except, is it a volatile liquid with sweet odor? Does it sensitize the heart to adrenaline? Does it constrict your bronchioles? Does it cause malignant hyperthermia? So again, we need to revise what are the salient features of halothane. So halothane is a halogenated ethane. It is not halogenated ether. Please do remember that it is a halogenated ethane. It is non-flammable and non-explosive. It is sweet smelling, so it does not irritate your respiratory tract. And so therefore, it is a second drug of choice after sevoflurane when it comes to inhalational induction in patients who do not have an IV line. It undergoes spontaneous decomposition. It has a molecular weight of 197 Daltons with a boiling point of 50 degrees Celsius, an oil gas partition coefficient of 197, which is quite high, making it a very potent drug, and a blood gas partition coefficient of 2.5. So therefore, you have a slow onset and recovery whenever you're inducing a patient with halothane. And like we saw, the oil gas partition coefficient is quite high at 197. So therefore, the MAC value is only 0.75. So what are the pharmacodynamic properties of halothane? It is a direct myocardial depressant and a coronary vasodilator. So whenever you administer halothane, you're going to have hypotension and a reduced cardiac output. There is going to be no secondary or compensatory bradycardia. It does sensitize the heart to catecholamines. That is something you need to remember. Halothane tends to sensitize the heart to catecholamines. It results in a rapid shallow breathing because your tidal volume tends to reduce, whereas your respiratory rate tends to go up. And on the respiratory tract, it causes a bronchodilation, not a bronchoconstriction. It results in bronchodilation. And as far as the effects on the central nervous system is concerned, it causes anesthesia without any analgesia, as opposed to your nitrous oxide, which does have analgesic effects. Halothane does not have any analgesic effects. It tends to increase your cerebral blood flow as well as the intracranial pressure. It also causes powerful uterine muscle relaxation. So this becomes the agent of choice for manual removal of the placenta. Again, this is something which is very commonly asked in your entrance exams. Please do remember that halothane is the drug of choice for manual removal of your placenta. Again, because of this bronchodilation on the respiratory tract, it becomes a drug of choice in asthmatic patients. So in bronchial asthma, the drug of choice for maintenance of anesthesia would be halothane. These are important things you need to remember as far as your entrance exams are concerned. Now, what happens when you administer halothane? How does it transform within the body? So what happens is your cytochrome P450 oxidizes halothane and results in the formation of trifluoroacetyl metabolites. This would result in autoimmune halothane hepatitis in those patients who are genetically susceptible to this condition. So some of the predisposing factors are exposures in middle age groups, exposures in obese individuals, female sex, and those with a familial history of halothane hepatitis. So all of these patients tend to be more genetically susceptible to your halothane hepatitis. And how does it present? It usually presents with a high grade fever along with jaundice, and hepatomegaly occurring 2 to 3 days after halothane exposure. And again, there are two types. You can have a type 1, which is the more benign variety, and type 2 halothane hepatitis, which is more fulminant and can result in a massive hepatic necrosis. It is lethal in almost 50% of the cases. Type 1, however, like we saw, it is benign. It is the one which is more common, thankfully, and it is often self-limiting. So the contraindications to halothane use are, of course, malignant hyperthermia, patients with risk factors for malignant hyperthermia, or a patient who has already had a history of malignant hyperthermia. You would not use halothane. Also, in those patients who have had intracranial space occupying lesions, you're not going to use halothane because it tends to increase your intracranial pressure. Also, whenever you have a patient with a high dose of epinephrine, he is in shock, he needs a high dose of epinephrine, you would tend to avoid halothane because it sensitizes the heart to catecholamines. Another thing is in patients with aortic stenosis. In aortic stenosis, you're going to have myocardial depression. Already there is a fixed obstruction to your cardiac output occurring in terms of your aortic stenosis. So therefore, any kind of myocardial depression would be catastrophic to these patients. So you would not use halothane in this condition. So with that knowledge, I think we can answer this question. Following is true about halothane except. So you need to identify which is a false statement. So we all know that it is a volatile liquid with sweet odor. So therefore it is used for induction of anesthesia whenever you do not have an IV line. We all know that it sensitizes the heart to adrenaline. So therefore you would not use it in patients who are receiving high doses of adrenaline infusion. It does not cause constriction of bronchi. It results in bronchodilation. So therefore it is a drug of choice in bronchial asthma, and it can have a incidence of malignant hyperthermia. So all of the other statements are true. It, however, does not cause constriction of the bronchi, and therefore the correct answer is C. So the next question, the anesthetic gas with maximum respiratory irritation is it halothane? Is it enflurane? Is it desflurane? Or is it sevoflurane? We all know that halothane and sevoflurane are the drugs which are used for inhalational induction of anesthesia. Sevoflurane is the one which is a drug of choice for inhalational induction because it causes lesser respiratory irritant action and it has a fast onset and recovery. Halothane is a second drug of choice for inhalational induction. Both of these drugs do not cause any respiratory irritation. Desflurane, however, is the one which is very irritant to the respiratory tract. Please do remember that desflurane is irritant to the respiratory tract, and therefore the correct answer is C, desflurane. The next question, the least MAC value is of which inhalational agent? Is it xenon? Is it B, halothane? Is it C, sevoflurane? Or is it D, isoflurane? So please do remember these numbers. We can see here methoxyflurane is with a MAC value of 0.16. It is the most potent. Xenon has a MAC value of 70. Nitrous oxide has a MAC value of 104 and it is the least potent. Amongst the commonly used ones, halothane has the least MAC value of 0.74. Desflurane has the most MAC value of 6.6. Isoflurane and sevoflurane have a MAC value of 1.15 and 2 respectively. So I think now that we have seen the MAC values of all your individual agents, we know that halothane has the least MAC value of 0.75 and therefore your correct answer is B, halothane. The next question, fastest induction and recovery is seen with, is it A, desflurane? Is it B, nitrous oxide? Is it C, halothane? Or is it D, enflurane? Again, these two mug up the numbers. Xenon has a blood gas partition coefficient of 0.14 and therefore it is a fastest onset and recovery. Methoxyflurane has a blood gas partition coefficient of 15, therefore it has the slowest onset and recovery amongst the more commonly used. Desflurane has the lowest blood gas partition coefficient, therefore it is the fastest amongst the commonly used inhalational agents. So the fastest induction and recovery amongst all of these options would be with desflurane. Therefore, the correct answer is A, desflurane. The next question, inhalational agent of choice for neurosurgery is it A, halothane, is it B, enflurane, is it C, isoflurane, or is it D, nitrous oxide? Now coming to our question, halothane, we have already seen that halothane is contraindicated in intracranial lesions because it causes vasodilatation and an increased intracranial pressure. Nitrous oxide, like we saw, it tends to increase your air cavities. Whenever you have a pneumothorax or a pneumocephalus in your neurosurgery, you're going to open up your skull and therefore you can have a pneumocephalus, and this pneumocephalus can increase in size during dural closure. So therefore you would tend to avoid using nitrous oxide in neurosurgery. Enflurane, it tends to increase the intracranial pressure 1. Also, whenever you combine this enflurane in a patient who is being hyperventilated, it can lower the seizure threshold and you can end up precipitating seizure attacks during the surgery. So therefore, the inhalational agent of choice when it comes to neurosurgery amongst the given options would be isoflurane, and the correct answer would therefore be C. Which of the following anesthetic is contraindicated in renal failure? Is it A, isoflurane? Is it B, desflurane? Is it C, halothane? Or is it D, methoxyflurane? So we've already seen that methoxyflurane is the most potent inhalational agent with an oil gas partition coefficient of 950, and therefore your MAC value is only 0.2. It has, however, the slowest onset and recovery because the blood gas partition coefficient is quite high at 12. Methoxyflurane, however, causes renal toxicity due to generation of fluoride ions, which can result in a vasopressin resistant high output failure, renal failure, and it is also hepatotoxic. So therefore, amongst the given options, your anesthetic which is contraindicated in renal failure would be methoxyflurane, and therefore the correct answer is D, methoxyflurane. The next question, smooth induction is seen with, is it A, ether, is it B, halothane, is it C, isoflurane, or is it D, desflurane? For this, again, we need to look at some of the salient features. We're talking about induction of anesthesia with a volatile agent. So you would want something which is not irritant to the respiratory tract and which has a fast onset and offset of action. We all know that halothane and sevoflurane are the ones which are non-irritant to the respiratory tract. Isoflurane and desflurane, however, are irritant to the respiratory tract, and the onset and offset of action is determined by the blood gas partition coefficient. Desflurane has the lowest blood gas partition coefficient amongst the fluorinated anesthetic agents of 0.42. Halothane has a blood gas partition coefficient of 2.4, making it the slowest to have its onset and offset amongst the commonly used, clinically used volatile anesthetic agents. Isoflurane and sevoflurane are somewhere in between. Again, please do remember that desflurane causes transient sympathetic stimulation and the airway reactivity is the most with desflurane. So smooth induction, therefore, amongst all of these options would be with halothane because all of the others are respiratory irritants. The next question, which of the following sensitizes the myocardium to catecholamines? Is it A, sevoflurane? Is it B, isoflurane? Is it C, ether? Or is it D, halothane? So amongst all of the options, the correct option which sensitizes the volatile anesthetic which sensitizes the myocardium to catecholamines is therefore halothane, and the answer is D. Next question, the anesthetic agents which have a tocolytic effect are, is it A, halothane, is it B, enflurane, is it C, isoflurane, or is it D, all of the above? So what do you mean by tocolysis? Tocolysis means refers to the uterine relaxant property, toco and lysis. So you're going to have a uterine relaxant property. All of the halogenated agents tend to produce a dose dependent tocolysis or a dose dependent reduction in the uterine muscle tone. So this includes your halothane, enflurane as well as isoflurane. And this uterine relaxation at higher doses, however, tends to predispose the patient to your postpartum hemorrhage. So amongst all of those options, that is halothane, enflurane and isoflurane, halothane is the preferred tocolytic agent for manual removal of placenta. We've already seen that it is a drug of choice for manual removal of the placenta as well as internal version. So amongst all of these anesthetic agents, halothane, enflurane as well as isoflurane, all of them can result in a tocolytic effect. So therefore the correct answer is D. These are all high yield topics often asked in entrance exams. So please do make it a point to remember and revise these numbers often. Thank you.